So we have time, today the time is broken up a little bit weird, partly because of our guest speaker that's coming for Grand Round. So we're gonna have the case between 3 and 4 that he's scheduled to be with us. He may come back for this, we wanted to talk about the sprint trial, which Master's in, and so we're gonna hold off on doing that first. So for starters, we'll start off with these bioresorbable stents. This was presented at PCC.
All right, so I have the Absorb trial. This is out in NEGM back in October. So this is looking at the,
Sorry about the email, but the vacation thing is just, I wanted to again address the one organization. All we do is just communicate with the interventional fellow. Something happened where everyone except the interventional fellow knew about a schedule problem, the scheduling, and that person wasn't planning on being in the lab. And Ari was left to his lonesome on his very first day ever in the Cat 5 schedule, which is not fun, because you don't really, let alone perking and getting, doing all that. So we just want to try to minimize stuff like that in the future and to keep things going. So sorry for keep sending those things out, but Kate already did a good job of saying, I want the 28th out. I've already talked with Bill, I forget, someone had clinic, someone had clinic on Tuesday. We'll cover at least 2 people in the lab. That's all you need. I wanted to say, these 2 people are aware, CC'd on the email, so then everyone is very clear about it, and it's just a communication. So, and with that, sorry.
interrupting my,
Your flow. It was so good.
So, I'll try. So this is the Absorb trial with looking at the bioresorbable stents with the everolimus coated scaffold. So I guess a little bit about the bioresorbable scaffold. So as you know, with bare metal drug-eluting stents, there's always concern with the residual metallic stent that over time you get in-stent restenosis. And the thought process is with the bioresorbable stent that as they degrade over time, we'll get the return of the normal vessel vasculature and vasomotion. And typically, the stent that they have right now, the Absorb stent, it consists of 150 micrometer scaffold, and then there's a 7 micrometer eluting drug around it, which is everolimus in this case. And they've done some minor studies with this, like small registries and modest-sized randomized trials, which found no significant difference in terms of adverse events when you compare the Absorb scaffold versus designed cobalt chromium stent. But none of them have been adequately powered for clinical endpoints. So the objective of this study was, it was a large multi-center, single-blind study with active treatment to determine the relative safety and effectiveness of Absorb scaffold versus the designed stent. And it's really it was really powered for non-inferiority to make sure this is this at least as good as placing designed stent. So the inclusion criteria for this study was anyone that was 18 years or older and some evidence of myocardial ischemia. But they exclude anybody with acute coronary syndrome unless they had unstable angina. They had to have stable, unstable angina, silent ischemia for the most part. And if they were undergoing PCI, it would have to be either in 1 lesion or 2 lesions involving native coronary vessels in separate epicardial coronary vessels. So, for example, if they had a lesion in the LAD and diagonal, they'd be excluded. So that would be 2 different lesions in epicardial vessels if they were going to get 2 stents. And each lesion had to be no more than 24 millimeters in length, and the reference vessel diameter has to be at least 25 millimeters. 2.5 millimeters. In terms of exclusion criteria, they excluded anybody with an acute MI, which they defined as anybody with STEMI or NSTEMI, anybody with an EF less than 30%, anybody that's not chronic anticoagulation, and complex lesions, which there's a whole, if you read the supplementary appendix, there's like a whole bunch of exclusion criteria, but there's just a couple of ones I pulled out. And in terms of the study protocol, everyone received at least 300 milligrams of aspirin within the 24 hours before the procedure, and then they received a P2Y 212 receptor antagonist either right before the procedure or within 1 hour after the procedure. And before the stent was placed, they did predilation of this target lesion, and then they were randomly assigned in a 2-to-1 ratio to either receive the bioresorbable scaffold or the designed stent. And it was a single blinded study because obviously the operator knows what they're putting in, but the patient didn't know what they were getting. So the primary endpoint they were looking at was for non-inferiority, was for target lesion failure at 1 year. and they defined target lesion failure either as cardiac death, target vessel MI, or ischemia-driven target lesion revascularization at 1 year. And in terms of secondary endpoints, they looked at 1 year rates of angina, all-cause revascularization, and ischemia-driven target vessel revascularization. This is just the characteristics of the patients at baseline. They were good at cross-matching, and there was no significant difference in terms of comorbidities or, I guess, what vessels they stented. So for the most part, they were pretty effective in terms of cross-matching. So this is a table looking, I don't know if you guys can see it up here, this is a table looking at the procedural outcomes. And so they had, if you look at the two, this is the absorbed scaffold on this side, and this is the Zion stent on this side, and it's a 2-to-1 ratio. And if you look at device implantation, they were more successful in terms of device implantation with the Zion stent, and it was statistically significant. And if you look at least 6% of the time, they had to abort placing the bioresorbable stent. They could put either to whatever the operator's discretion another stent, whether it was designed or something like that. And the procedure duration was also longer in the scaffold group as well. So the device success was statistically less it was less successful in the absorbed scaffold versus Zion stent when you compare device success. And what they defined as device success was successful delivery and deployment of the stent, and there had to be at least less than 30% residual in scaffold stent residual stenosis. But if you look at procedural success overall, it was actually not any different in terms of the two stents, which they defined as the occurrence of cardiac death, target vessel MI, or repeat target lesion revascularization during the hospital stay up to 7 days. So from a procedural success standpoint, there's no significant difference between the two groups. The only other things maybe I guess I could bring to your attention is, in terms of if you look at the in-device measures between the two stents, in terms of the scaffold versus the Zion stent, the luminal diameter was, they were more effective in terms of, I guess, after dilation with the stent, in terms of having a greater luminal diameter. But that could also be a product, I think, of the stent, scaffold stent also being a little bit safer as well. So this is for the primary endpoints, which is target lesion failure. So at 1 year with both the scaffold, the absorbed scaffold and the Zion stent, there's no significant difference between, in terms of target lesion failure, whether it's cardiac death, target vessel MI, or ischemia-driven target lesion revascularization. And then in terms of secondary endpoints, there's no difference in any MI or revascularization. One interesting thing is that in terms of overall stent thrombosis, if you look at overall, there's no significant difference, but when you break it down into early versus late, where there's acute less than 24 hours, greater than 24 hours to 30 days, and then late 31 days to 1 year, in the group with, there was more subacute thrombosis in absorbed scaffold, which is defined as 24 hours to 30 days. But when, this is also in the intention to treat analysis, like when they did a post-hoc analysis with the as-treated group, they didn't find a significant difference. So it's hard to say if this, is this something to be worried about or not, but they did find that the subacute thrombosis was higher in the absorbed scaffold versus the thrombosis stent.
So a lot of the scripts changed, and so is that part of the reason of failure, that they weren't able to place the absorbable stent and convert it to a
So they don't define what caused the operator, because it was a multi-center study, but at least 6% of the time they aborted using the absorbed scaffold for some reason, whether they didn't like the deployment, they didn't like the swimming pool afterwards.
So this is as or an intention to treat?
This is intention to treat.
Okay.
But when they did the post-hoc with as treated, they didn't find the same difference. But what's interesting is when they went back and looked at, so after they saw it, they went back and analyzed the smaller trials they had before, and they also found the subacute thrombosis as well. So it's going to take some time to figure out if this is legit or not.
So would you mind commenting about the nature of the bioabsorbable and how long it takes to disappear from the vessel, and what is the balloon mounted?
It is balloon mounted, and it starts dissolving within 3 months, as they say, and I think it takes at least 2 years to have it completely dissolved. But they say 2 to 5 years. And all these, right now we only have outcomes for 1 year, and I was going to get to it later on, like, we might have to wait longer to see is there any truly clinical benefit long term, because this bioresorbable stent is technically still there right now. So it's just a time event, the same thing in terms of, target lesion failure 1 year, which is about 7.8% versus 6.6% in the Zion stent, and it wasn't statistically significant. And this was just a subgroup analysis. They looked at the patients that had target lesion failures, and they tried to do a subgroup analysis to see if there's any, common factor that explained what was causing these people to have target lesion failure, and they found nothing significant that could explain, the differences between the target lesion failures. Whether it be comorbidities, target lesion, if they were using critical versus tactical.
If you look at that, it almost looks like if they just did a 1-to-1 comparison versus a 2-to-1, you probably would gain power significantly in everything and shift it over to the Zions is better at least at 1 year. I mean, who knows where the numbers will flush out, but if you go back to table 1, there's a lot of things that point p-values of 0.1. You know,
It's trending towards them, yeah.
and that's in a 2-to-1, which should show any power, assuming, I don't know where the adverse event rate you think will probably be
Yeah.
it's hard to tell, but you think it might actually tighten those confidence intervals if you add that newborn to the Zion's arm.
Yeah.
And you probably would get a lot more statistical significance.
That's a good point. So in terms of limitations, I think one of them was, most of the people that we end up doing PCI on are people with ACS, and they excluded anybody with ACS. It was anybody with stable symptoms and non-complex coronary lesions. It was also underpowered to really, examine like low frequency events, such as like stent or scaffold thrombosis. And what Ziad was saying was, the bioresorbable stent is really, the benefit might only be seen beyond the 2-year mark that we're looking at. So we might have to extend the study out longer. We might not know for years if there's truly benefit from having these scaffold stents versus the metallic stent that we have right now, in terms of giving it some time for it to absorb to begin with. So in summary, the bioresorbable stent compared to the Zion stent was non-inferior with respect to target lesion failure in 1 year, and there's no significant difference in terms of 1-year rates of angina, total revascularization, and ischemia-driven target vessel revascularization as well.
I'm going back to that curve 1 year.
Yeah.
So this is a failure, right? So the scaffolding, they are really higher, but the p-value is 0.1. But if you look at the actual confidence intervals, they're large. So like Matt was saying, I don't know if a number go up on the actual, a number on the science group, you might actually see a problem.
Yeah.
Because
I've always had a problem with the paper. We go back to the very beginning of this procedural success. Right? We're looking at device. If you really want to ask the question, right up front, should I use a bioabsorbable versus science? I would look at device success, right? But here we're looking at after the stent is placed. If you're going to ask the question, can I get this across in an intervention? They're not even performing that analysis because you have a fair number of failures right up front on the device utilization. But it's, I don't know, early.
Yeah. And I think, I was thinking about last night was, I think, if this works, I think it could be a game changer in terms of, how do you treat diabetics? Because you can potentially stent diabetics and you can still get bypassed. Allograft vasculopathy, we have these patients who are always concerned about putting stents in because inflammatory state, but if you have bioresorbable stent, you can keep stenting away, really. And it might be beneficial in those kind of cases, so.
Restenosis rate with the bio.
We don't know yet.
But these studies have been done in other countries, right?
yeah, Europe,
Yeah, I don't know the data on that.
there's a huge meta-analysis that actually found no difference between the regions in the US and
What time
for restenosis. And then I think their follow-up is also not long follow-up. They're also wanting to do follow-up.
What happens relatively early
Actually,
anyway.
most of the time they talk about either target vessel or target lesion. And I think their main difference, if there is a difference, is target lesion and no difference. So it's a difference. But there is a huge meta-analysis, like 200 companies.
Oh, wow.
Yeah, from Europe. Yeah. So yeah, you're interested.
I think the power of these bioabsorbable stents is not in the short term. obviously they have to do the study over 1 year. But if we think that it's truly a total absorption or resorption of the entire scaffold. And in drug-eluting stents, you have this perpetual rate of closure of the artery, even after a couple of years. I think it's like 0.5% per year forever. That if you can get rid of that, maybe you actually could decrease that rate of thrombosis, number one. And then number two, the thing that we talked about already, but I think it's just something is when you have a vessel that has this really like a diabetic vessel with long lesions and ones that are considered that if you put a full metal jacket in, that you completely take away the possibility of cabbage later on. That to me is the potential place of drug or the trial of drug could be really remarkable.
I don't
Yeah, they were.
I don't know.
You're gonna struggle though to get a clinical, data-driven point to that, right?
Sure, yeah.
We have how many years of treating coronary disease, interventionally, cabbage at 30, 40 years, millions of patients, all this. And then it's gonna be really hard to convince people, and then to come up with robust data to show, it's gonna be 10, 15 years. Before we're there.
Right.
I'm not sure that it's gonna be better. I just
Bypass, left main bypass, left main stenting. We know that stenting might be okay, but we still don't do it, because we don't have that longevity.
Right.
I know there is a very rare population, but there are patients that are allergic to stents, do they have any way for like those patients to go?
All the bioresorbable.
Yeah.
Oh, I don't know my option.
No, they're usually allergic to Nico and other components of the stent. They try to hide inside the metal.
What is that? Is the allergic response isn't there anyone nowadays?
They say it's real.
Yeah.
It doesn't happen very often, but it's real.
I don't know.
They have Nico
Yeah.
on the stent.
What about chromium is the most common component of the stent? But there
Yeah,
is
it's about
nickel.
3 or 5%
Yeah, there's a-
of the, and it's kind of hidden inside the max.